What time do you guys have? Noon?
Just 12, just turn.
All right. We got 12 people in the waiting room. Do you want me to go ahead and let everybody in?
I would let them in. Keith, if you want to ask everybody to put their name and contact info or their name and organization, I guess, in the chat,
Yep.
we can give folks another minute or so to join.
Okay.
You think we're good, Colin?
Yeah, for sure.
All right.
Good afternoon. If you wouldn't mind, while we're ready, we'll get started in a few minutes. If you could put your name and your organization in the chat, we would appreciate that. Good afternoon, everyone, and welcome to Bright Views Columbus Community Forum, Improving Outcomes in High-Risk Patients. My name is Keith Queener. I am the Community Outreach Manager for our East location, and I also want to introduce you to Brittany. Brittany?
Hello, everyone. My name is Brittany Wallace, and I am the Community Outreach Manager for Columbus West. Nice to meet you.
Awesome, awesome. We're excited to see so many different partners interested in learning more about Brightview. Before we actually get started, I want to do some general housekeeping for this forum. Please mute your device or computer. If you have any questions during the forum, please utilize the chat. We'd be more than happy to answer those questions if you use the chat. And as things are going, if you think of something, please put that on there. If we don't get to it, myself or Brittany would be more than happy to get those answers to your questions. Before we get started, a quick review of our agenda. The forum will begin with an overview and who we are and why we are here today, as well as our medical and clinical best practices. We'll be discussing improving virtual care, improving patients and outcomes. And we'll wrap with a discussion, a question and answer period. I want to introduce a brief introduction of people who will be speaking to you today. Our founder and chief medical officer, Dr. Sean Ryan, will be speaking with you today. Also, Dr. Nav Kang, our chief clinical officer, and Nate Pelletier, our vice president of developmental initiatives, will be talking to you guys today and giving you information. I will let them introduce themselves and talk a little bit further about themselves. Dr. Ryan?
Thanks, Keith. So as stated, I'm Dr. Sean Ryan, original founder and current president and chief medical officer of Brightview. Just a little bit of history of how we came to be here many years after we started this journey. As an emergency physician and a hospital administrator for Mercy Health, really saw an absolutely disastrous and growing need for substance use disorder treatment that was high quality, evidence-based, and to some extent focused on the opioid epidemic at the time, about a decade ago. We've done a lot of great work since we started with that strategic vision, which was fairly simple. And it was, do the right thing by the evidence and the guidelines, also do the right thing by the patients, and make sure we're ready and available to treat them when they're in need. Sounds simple, but those were all things that were not present in the field at the time that I started to really focus on it, and has grown us into, I believe, 38 sites in 3 states now as part of our growth to meet that need. I think most folks are aware, unfortunately, COVID made a significant dent in the progress we were all making around substance use disorder. And now Brightview is refocused on continuing to grow to meet the needs throughout our communities related to increased substance use disorder issues, again, partially related to COVID. I'll turn it over to Dr. King for a brief intro.
Thanks, Dr. Ryan. As stated, I'm Nav Kang. I'm a psychologist by training. I've had the opportunity to be the chief clinical officer here at Brightview for about 2 years now. Dr. Ryan, Nate, and I have collaborated for many years prior to that, though, and so we're very lucky to have the team that we do. I think, for my part, what you'll hear from us is how proud we are of the services that we offer, and some detail on what those services look like, and just how accessible that they are, and how effective we find our outcomes to be for our patients. But in the end, I hope you also take away from this discussion just how critical the relationships we are with folks such as yourself. So very grateful for the fact that we've got a couple dozen folks who have made time out of their day to join us for this discussion. In the end, our patients come to us with a complex set of problems, and we seek to deliver a highly integrated model of care. But we can't be as successful as we want to be without strong partnerships with other stakeholders in the community. And I think the effectiveness and accessibility of our program is one thing, but the transparency with which we work with others is just as important. And so great opportunity today to have some dialogue on what that partnership can look like with you all. Nate?
Thanks, Dr. Kang. Nate Pelletier. I've been working with Dr. Ryan and Dr. Kang, it seems like, for almost half a decade now on this topic, and been a real pleasure working with them and the Brightview team and learning about how we continue to progress. So in my role at Brightview, as we continue to grow our footprint to cover down in areas that require and need our services and filling those gaps, which is a true part of our value proposition, I spend a lot of my day trying to figure out how we build partnerships at the community level. Most importantly, figuring out what the needs are of certain populations that we have at Brightview, with a heavy focus on the criminal justice patients that we have, fully just knowing that they have significant requirements and accountability to ensure that we're meeting the expectations of what they're dealing with in the justice system and their partners, as well as continuing to provide them the quality of care and making sure that those are working collaboratively. So really look forward to the dialogue today, and particularly any of the questions that you have. Thank you.
Awesome. Brightview is a comprehensive outpatient addiction treatment center using clinical research and best practices to provide the best care for our patients. We continue to focus on collaborating with community stakeholders by partnering with criminal justice systems, working with Adam boards, and volunteering our knowledge on MAT and clinical practices. At Brightview, we are proud to offer 24/7 patient access center, online scheduling, and an ability to accept walk-ins Monday through Friday from 8 to 3. I'll turn it over to you, Dr. Ryan.
Appreciate it. So I'm going to talk just a little bit about the continuum of care for our patients. And part of the reason for this conversation in this setting is to understand how many settings are, patients traverse across time while they're in course of care. And that includes, of course, the criminal justice setting where they unfortunately may be in and out of during the course of their recovery, hopefully. But the continuum of care that you're seeing here is a pretty basic outline of what we hope to continue to build in most communities. Brightview really provides kind of the points 1 and 2 here, the outpatient and intensive outpatient components of this. And we partner with other folks who do the other things like residential or inpatient primarily being in a hospital or highly medically monitored setting in order to try to build that continuum. But it's not really this consistent in most communities that we work. We've chosen very specifically to develop the services I discussed, and we'll talk about a little bit more. But there's a long way to go. And so because of this patchwork, it's really important that we do partner with community folks who are either within this continuum or parallel to this continuum, as an example, criminal justice setting, in order to make sure that folks are staying in some version of that continuum, because falling outside of it is really where we see issues. I'll give an example. You can see in bullet point 3 here that detox only is consistently shown to be ineffective and increase overdose deaths. But we know that a lot of folks go through this. They'll go to just a detox for 3 to 5 days, or they may unfortunately get detoxed in a jail or prison setting. And then they won't get placed on medications or get long-term therapy plans or any of the holistic treatment that Brightview provides, as do others. And that leads to problems. In fact, in most settings, if you just detoxify someone from opioid use alone, their chances of overdose and death are quite a bit higher. So not only is it bad to not be in this continuum, but can actually, some components of it delivered separately can actually be quite dangerous. The other part that I'll just mention on this slide is that we know that only about 1 in 5 patients are actually getting the care that they need, and about and the point on the top here, only about 1 in 5 patients actually need inpatient setting or bullet point number 4 on this continuum. So those two stats are a little bit in stark contrast, because inpatient, what we're saying about that is there's a disconnect that a lot of people think if you have substance use disorder that's severe, whether it be alcohol or opioids, you need inpatient treatment for 30, 60, 90 days, or if it's just in a hospital for 5 days. And that's just really not true. So approximately 4 out of 5 patients can actually be cared for in the outpatient setting that Brightview provides. Unfortunately, like I said, only about 1 in 5 patients actually gets any sort of care in the system in the United States today, which is part of the reason we're seeing such disastrous worsening overdose deaths throughout the country related to all kinds of substance use disorder, including alcohol, methamphetamines, and opioids. So I'll finish with, speed to treatment and getting into part of this continuum, wherever that may be, is the most crucial thing you can do. There are several studies that have pointed out that patients that are getting some level of treatment, if it is not the best for them, but some level of treatment is a significant mortality reduction or reduces their overdose risk. But of course, the best case scenario is to have these levels of care available and get the person put into the right one as designated by the ASAM criteria. And again, just to reiterate, bluntly, wait lists are unacceptable and they can be life-threatening for folks with substance use disorder. Next slide, please. I'm going to spend just a few minutes on the medical best practices of Brightview Health. So I'm the chief medical officer and generally responsible for a lot of these medical best practices and writing some of the literature, responding to it, reflecting it into our practice. And the reason that's so important to me, first and foremost, is for our patients. We're taking oath as medical providers to do the best for our patients at all times. And so that's the guiding principle under which we operate. At the same time, I train at a very academically focused medical center at the University of Cincinnati in relation to emergency medicine. And so the concept that we would treat medical conditions like substance use disorder with anything other than medical best practices is not only unacceptable, but completely foreign to someone like me who trained in that setting. Good news is the literature continues to come out to support the delivery of care that we put forth. What's, I guess, in contrast to that is sad is that literature has actually been pretty much the same for several decades. So the fact that we're still talking about 1 in 5 patients getting good treatment or whatever version of that statement you want to make is really sad. In 2016, the Surgeon General came out and put out a new report. It had been several decades since they had done one on alcohol and substance use disorders. And it talked about things that have been known since the 60s, such as the top check marks here, that utilization of the appropriate medication-assisted treatment reduces the things we all care about in our patient population, including associated criminal behavior. So less relapse and less re-engagement with the criminal justice system, which I think we all appreciate as an important point. In regards to the medication, we do deliver all three types of FDA-approved medications, and we use other medications, including mental health medications, some medications off-label because there's not always a FDA-approved medication for certain substance use disorders. But for opioid use disorder specifically, we do use methadone, buprenorphine, and naltrexone, or you can see some of the brand names here. What's important about this is that we have to abide by the guidelines and the FDA approvals and the things that we know that are best case for patients, and that includes dosing. So the literature is pretty specific on that. And that really should be left up to the medical provider. There's a lot of instances in which people put forth concepts or ideas about dosing, but they would never do that in other settings. I've never been told in my entire life by a non-medical professional what aspirin or insulin I should prescribe for a patient. But in all reality, we have a lot of issues with folks interjecting opinions on which types of medications and dosing and duration and such and so on. What I can promise to you folks is the fact that Brightview monitors this literature, this research, this evidence constantly. We have so many medical directors that are board certified addiction specialists. We're very lucky to have them. And we read this literature constantly as it comes out, and we stay absolutely on top of the best practices we can deliver as things change. And the last point I'll make as an example is, as we went from prescription drug abuse and use to heroin to fentanyl, that all required changes in dosing and strategy and things that are very complicated neurochemically. And that's why we really do promote that the medical professionals at our treatment centers are responsible for maintaining that best plan for the patients. And also, as you can see on the slide here on the right, consistently making sure that patients get treatment in a timely and readily accessible fashion. I think I'll turn it over to Dr. King at this point.
Thanks, Dr. Ryan. Yeah, so similarly how, as Dr. Ryan referenced, our medical team is quite large, comes with hundreds of years of experience in treating patients with substance use disorder. Our clinical team is similarly large, or actually significantly larger, just because of the ratio of patients to staff. So we've got over 200, almost 250 clinical providers across the Brightview system now. That includes our counselors, our social workers, our various types of therapists, case managers, peer recovery supporters. Each of our sites has a clinical supervisor who has a master's degree and an independent license, but also 90% of our counselors also have that master's degree. And if they don't have their independent license already, they're actively in the supervision process to achieve that. So quite proud of the tremendously talented and experienced workforce that we've been able to pull together across the Brightview system. So I'll talk a little bit about the care that we provide, just to give some concrete input on this front. And then we'll talk a little bit about does it work, which I think is also a very important and relevant question to Dr. Ryan's commentary. So to give you some clear input on the services we provide: individual counseling, group therapy, case management services, family therapy as well, if we can access the family and integrate them into the patient's care. Not always accessible, certainly at the early stages of treatment if those relationships have been disrupted, but an important part of the treatment process, and we look to bring that into the mix as soon as it's relevant and feasible for us to do that. I think, when you stand back and you look at the biopsychosocial understanding of illness, meaning that substance use disorder is a chronic relapsing medical condition. It has a biological, psychological, and social cause. The framework that we're walking you all through right now is just simply born from that understanding that means we should have a medical intervention that goes with that, psychological interventions that go as part of that treatment package, as well as social interventions as well. So counseling component is quite robust, as is our case management service. So each of our centers has case management and peer recovery supporters who work with patients on some of the most basic social determinants of health, starting from their first day in treatment, all the way through longer term goals like having a resume and the clothes to wear to a job interview and the skills associated with navigating that process successfully. And so quite proud of the fact, and again, we'll talk about it here in a couple of slides, the impact on patients is not just limited to reducing mortality risk, which is a critically important first step, obviously, but is part of a more multidimensional impact on patients. And that's thanks to the very comprehensive team that we have built. And we're quite clear with patients right out of the gate on the importance of that entire treatment package that we offer. If patients participate in less than the whole package of treatment, then the benefits that they derive from that treatment package are less than what they could achieve. And so we're very clear with folks on how, engaging in our full program really provides them with a whole host of benefits, and that those gains that they make in their quality of life and everything else really can be solidified as part of their recovery process. A couple of quick notes on harm reduction. If you're attending this discussion today, you're probably somewhat familiar with the practice of addiction medicine and the historical ways of operating that Dr. Ryan alluded to. But then also I want to talk about the historical ways of actually practicing and how we seek to disrupt that. So I think addiction treatment is probably the only area of healthcare where an adversarial stance with patients is historically the norm. Could be wrong about that, but it's certainly the most prominent, meaning that if patients are struggling with their condition, historically addiction treatment providers have used things like 3 strikes rules or 30-day blacklists or this kind of thing that, you can't come back here until you go get your mind right or something else. And that's just not how we approach patients in any other area of healthcare. Instead, we treat folks with dignity and respect, and we treat them with compassion as they move through the change process, because guess what? People with chronic diseases are people. And like all of us, we're ambivalent about change, and, we move up and down the motivation spectrum all the time, and patients with substance use disorder are no different. And so folks are going to struggle with their condition. It oftentimes takes years for the illness to progress to the point where treatment is sought. And so we need to reflect the understanding that folks aren't just going to change overnight, and keep their safety in mind. So we practice in what we call a harm reductionist, non-punitive clinical philosophy. And what that means is just that we would never fire a patient from treatment for struggling with the condition for which they're seeking our help, right? We don't do that in any other area of healthcare. Can you imagine if you went to a primary care provider for diabetes care management, you're struggling with the lifestyle change they want you to make? You're not dieting and exercising the way that they are encouraging you to. Can you imagine if they called your blood dirty because your blood sugar was elevated or your hemoglobin A1C was elevated? Can you imagine if they said, I'm not taking care of you anymore, good luck, turn around and walk out the door? We don't expect that in any other area of healthcare. Can you imagine if your loved one was treated that way? And so we shouldn't practice that way in this space either. We should treat folks with that kind of patience and grace that I think all of us would expect for ourselves, for our loved ones, and in other areas of healthcare too. And again, safety is the central element to that, right? That if the patient is going to be made less safe by us taking some action, we're not going to take that action, right? Or if we can ensure their safety on some even incremental level by continuing to work with them or providing some other new intervention, then we'll help them in that way. We're in this for the long haul with folks, and we want patients to know that from the first day. When we get to know them and genuinely express curiosity in their journey, we want them to know that as things transpire, for the good, for the bad, whatever you want to call that, we're going to be there with them to walk those steps. Next slide, please. So to the question of does it work, right? People oftentimes ask us this question, and rightfully so. I think to Dr. Ryan's commentary, the literature has shown for a while that if you translate a comprehensive biopsychosocially informed treatment model to treat people with substance use disorder, that you can achieve stability rates that are remarkably in line with other chronic disease states. And so that's all great. That's all in the literature. We seek to translate science into practice here at Brightview. And so we wanted to look and see what actually happens for our patients using our treatment approach. And so we look back in time, 3 years now of data collection, over 10,000 Brightview patients. As they engage with our treatment, what happens for them? Do they change? If so, in what ways? And if they don't, then where do we have room to improve? And what we found is that patients change in essentially every way that we can measure. And subsequently, we've gone to great lengths to verify what we have found through some of our largest payers and through other claims-based data sets and other things that can help us understand like the validity and reliability of the data that we have put together. But basically, I'm not going to read the slide to you guys. You can take a look at that, and happy to share this slide deck with anyone who's interested. But the idea is that as patients engage in our treatment in very rapid fashion, we see that their life changes in every way that we can conceive. So they are sleeping better at night, they're less depressed, they're less anxious, they're using the hospital less for psychiatric or medical reasons. That's emergency room and inpatient. We cut unemployment in half by about 6 months, so that takes a little longer than some of the other more acute stability kinds of components to it. And obviously folks are using substances less, alcohol, other drugs, should probably mention that too. And they're significantly less engaged with the justice system, less time in jail, less arrests, disengaged from the justice system if they were engaged before on probation, all of that kind of stuff. And so very proud of the impact that we make. I think for me, what's most important is the fact that not only are those gains made and we achieve those gains sometimes in 90 days, as you can see on the slide here, but they're also maintained for over a year. And so the idea of us changing folks' lives for the better, and not just in keeping them alive at the beginning, but helping them become reintegrated with their family and with their community, it's very fulfilling that we're able to achieve that. And it instills hope, I think, for our patients and again, for our communities that we can turn this crisis around. Next slide, please. So obviously difficult to have a discussion nowadays without talking about telehealth, or how does technology inform treatment? And so I think a couple of quick notes for us at Brightview is that we've long utilized technology to augment our care delivery, right? And so 24/7 call center is a simpler use of technology, simpler to conceptualize, difficult to implement. You can ask Dr. Ryan about that. Online scheduling, I think this one's a key. Online scheduling for a prospective patient, or if you want to schedule on behalf of a patient. So when I was in the hospital setting, again, the legacy addiction treatment system would say, I have to get the patient on the phone so they can prove to me that they're motivated before I give them an appointment. We don't need that barrier in place, right? Just like we don't need all the other barriers that Dr. Ryan referenced. So when it comes to being able to schedule on behalf of someone, if you're a probation officer, if you're a case manager, social worker, discharge planner, care coordinator, whatever it might be, if you've got someone in front of you who needs an appointment, if you're an EMT who responds to an overdose scene, fireman, whatever it might be, right? You've got someone who needs an appointment. They can leave that interaction with you with a defined appointment in hand, day, time, location, etc. And you don't have to talk to anybody on the phone. You can, our team will answer the phone in less than a minute, 24/7, but you can also just do it online. And then obviously telehealth, we've seen an expansion of that nationally in every domain in healthcare. The good news for us at Brightview was that we've been doing telehealth for a couple of years pre-COVID. And so the technology was not something we really had to figure out. For us, for Dr. Ryan, myself, it's been more working with our teams on the quality of the service. How do you establish a therapeutic rapport with patients in this modality for your medical and for your clinical services? Group therapy specifically, when you're doing the Brady Bunch style Zoom orientation, how do folks feel connected to each other, a sense of cohesion amongst group members? So we're the ones who are responsible for building that capability and that sense of skill within our teams. And we seek to make our services as accessible to patients using technology as we can. In the end, what we found is that the vast majority of our patients still prefer in-person services. And so the in-person aspect to care, the idea of coming into our center, seeing our team, seeing each other for patients is quite meaningful. And so about 15% of our visits happen via telehealth, but the vast majority, 85% plus, still happen on an in-person basis. I'll throw it over to Nate. He'll talk a little bit again about our transparent communication and what you all can expect from us in terms of how our patients are doing.
Thanks, Dr. Kang. Yeah, there's a general theme through all of this. What we're really focused on is what is best for the patient, not as what is status quo for treatment. So a lot of the things that we look at are, Dr. Kang is revitalizing, continues to optimize the clinical program. And of course, Dr. Ryan is the catalyst for the whole program, but, looking at the best way to look medically, we have to get down to the root, issues with our patients and understanding where they're coming from and not just treat them all the same. you can treat people with compassion and respect as we all have, but people are coming in with different kinds of barriers and issues. And it's important for us to learn how we adapt. So as I had mentioned in the intro, part of that is really understanding is very obvious. And many of you are on this call because of this. The criminal justice system has a intersectional relationship with, treatment. And with us and being, having so many locations and spread out through Ohio, we've seen the implications of that, and also have come down to know that every county and area in Ohio is sometimes a little bit different in how they manage or their perception of criminal justice and the relationship with a patient receiving treatment. So we've taken that all into account. So over a year ago, I was asked to really look into this and how do we improve? And, again, as Dr. Kang and Dr. Ryan alluded, in the sense of transparency, we weren't really doing a great job at it, not because we intended to, but we didn't really have a good understanding of the need. So as we dove into it, we realized, going through some, working with our team to understand their insights on the criminal justice relationships, as well as surveying many of you that are working in the system, to understand what are the drivers or pain points that either create an opportunity for best-in-class partnerships, which lead to better coordination and a service to the patient, and what are some of the barriers. To fast forward through it, it came down to really two very intuitive pieces. And those are, from what we learned, that we expect, we being the criminal justice system, very, very transparent communication, and we expect to have the information on the status of those patients who are involved in the criminal justice system when we need it. So what we found is then two things that we needed to address. We needed to figure out what information is actually needed, and is it communicated in a way that's effectively understood? And then what is this op tempo that we can create to get that information out there? The challenge for us is that since we have so many sites, the goal would be to make sure that it's standardized and consistent across the company. We can't have 20 plus sites all doing things 20 different ways. But what we found, luckily, is that more often than not, if information was shared to a probation, parole, or court on a patient on every 2 weeks, we were more than enough meeting that expectation. Now, granted, disclaimer, there are certain circumstances where that is different and we need to customize for a certain court or patient. But on average, I would say that is what we found. So we built a system where we got the information pulled together in a way that was meaningful. And we do that through a reporting mechanism, which I'll talk through. But we created a op tempo that was every 2 weeks. And one of the initial problems that solved was that anyone that's partnering with us, probation, parole, or court, will know exactly when they're going to get information on the patients that are involved. They don't have to ask for it. They don't have to beg. They don't have to factor in lead times and where they ask for it. In a way, they know that if they're working with Brightview and we identify a patient and they identify one of their probation, parolees, or court attendees, that information will come out every 2 weeks, and that makes it a lot easier for them to be able to plan, and it makes it a lot easier for us. One of the challenges that the clinical team has, that Dr. Kang can allude to, is that when you get a massive surge of requests on things that you don't plan for, it disrupts your op tempo and your scheduling for that day or for that week. And that was happening in kind of clumps around criminal justice, either a sense of urgency from a patient where we react to it, or a very disgruntled probation or parole officer calling and saying, I want to know what's going on with so-and-so. So having that op tempo every 2 weeks was really one major problem we solved to make sure, one, that they get the information when they need it. So within the company, we had to figure out how to best manage that so that we could continue to sustain it. So what we did is we realized that, one, we had to identify, well, how do we know if a patient's involved or not? So normally, our only mechanism was if someone was referred to us. So if we came from, we knew they were criminal justice if they were referred from the criminal justice system. But what's to say that a patient walks in or comes from an ED or another provider is also not involved in the system? So long story short, more of a technical issue, but we went in and made sure that in our healthcare records that we had a mechanism to be able, for the clinical teams to be able to identify those folks, and by identifying them on a consistent basis on their treatment plan, we would then trigger the need to have a report sent. Lastly on that, to back up, so what we realized that there are 3 different kinds of entries. There's the referrals, there's the patients that we can identify on day 1 through the induction process and are willing to share the information. And then there are 3, there are the patients that either don't want to share and share later in the program or unfortunately become involved. We are able to catch each one of those into our system to make sure that we have a strong utilization of the patients that are involved. Lastly, for us, what we realized is, well, how do we staff this? And normally it was our case management, but given some of the high caseloads that we had at the site, it became very difficult to do it. So we created a centralized position called the case management specialist. And that simply means that we have a very experienced case manager who's worked in Brightview, who's been put into this position, and they represent all criminal justice relationships and reporting for a region. So they will have maybe up to 200 patients, and they will have a region for you that's covered. I believe that Marani Lane is covering the Columbuses in that area, but they're there to add an extra level of service, customer service to you, and another person to be able to resolve any issues. So they will send out, gather the information from the clinical team, write the report, and get them out to all of you on at OpTempo. They will also work with the sites to dissolve any problems with ROIs and all of that. So just to increase that level of service to all of you that are in the criminal justice market, but also to drive efficiencies, and we can manage it at the site better. And ultimately, all of that comes together where the patient is appropriately represented. They know their information's getting out, and that we're really co-treating them and representing them in a way that is they should be represented. So it's been very successful. We appreciate all the engagement from all the partners on this, and we've seen ultimately the patients have benefited from the most. Last couple things that we have everything really centralized on our website for information. So if you are referring or dealing with the ROI, you can work with our outreach team, both Keith and Brittany. We have the ROI, which is a very important process, as you can imagine, the release of information. It's all on our website. It's all online. The intake forms are all on the website, and make it very easy and efficient for us to manage the referral to and the release of information of a patient involved in the criminal justice system and receiving treatment at Brightview. So, and I look forward to any questions you have. So.
Thank you, guys. I appreciate it, Nate. The importance of feedback. Your feedback is important to Brightview. You have you may receive an email or a text asking you about how Brightview is doing. It's a fast, easy way to gather information and to act on partner feedback. The responses that you give allow Brightview, our employees, to recognize how to become better at helping us access and how well our team is doing and how well our processes to support our stakeholders. It also allows us to identify critical resources for improving relationships, services, and processes for referral partners like yourselves. Most importantly, it gives our patients an opportunity to let us know what their experience was like. I mean, that's important because we want to make sure that we are treating all of our patients and our providers with the utmost respect and dignity. Next slide. Community discussion. At this point in time, if you have questions, please unmute your mic and we'll be more than happy to answer any of the questions that you have. Be more than happy to talk about it. For example, what are the biggest challenges and gaps in transitioning patients to effective treatment?
Can I ask a question real quick?
Yes, please.
Hi, my name is Jordan Lenser. I'm with Franklin County Adult Probation. I know, well, one, I like the harm reduction and understanding that this, as all other medical issues, is something that takes patience and continual efforts that don't include, okay, you're not complying, gotta go. Love that philosophy. By chance, have you worked with, since this is about criminal justice specific, have you, and I apologize if you went over this because I did have a couple phone calls and a probation who came in, but is there, are you familiar with the CBISA that a lot of probation is using, especially in Franklin County, and how we can tie that in where we're using the criminogenic needs that are identified by the probation or parole in the state of Ohio, or more specifically Franklin County, Ohio, that we are specifically working on, and how we tie that into a case plan that works for both agencies, the probation and parole, as well as Brightview, so that when we're getting, whether there are verbal, email, or fax update reports, it's tying in which criminogenic needs that are identified that need to be addressed, like criminogenic thinking, as well as substance abuse, so that, so that it's like one of those team kind of things.
Yeah, I'll answer that question, Joan. That's a great question for sure. So briefly, I think the answer is yes. There's obviously a lot of complexity to your question. So I'll give you some examples of how we've done it at some of our centers, including at our Marion Center. It's not in Franklin County, obviously, but is, I think, a good model of what we are able to do. And part of that is just simply informed by partners such as yourself. Like if we know what you need, then we can stand it up, in other words, right? So in several communities across the state, whether there's a grant associated with the court or the probation department, or an interest due to their knowledge from a subject matter standpoint, or part of the specialty docket considerations, the idea of having a risk assessment specifically for criminogenic risk or risk to reoffend and re-engage with the justice system is typically something that your folks may think about or even produce, or others as well. Obviously, county jail likely does something along those lines as well as part of the reentry process and everything else. So what we have done is when there is that interest and that kind of coordination need, we've stood up high risk and low risk men's and women's groups at our centers. That typically informs part of a patient's treatment. So a patient may come in for like the high risk to reoffend men's group for once a week, but then also come in for individual counseling and other group therapy in addition to their medical services. And then to Nate's commentary, our case management specialists are able to customize their reports to ensure that data is available to you all as well. So I think part of our program design is informed by what is the community need, and that goes to the micro level that you're talking about. So would love to have that conversation with you and say, what are some of the needs or the interests that you have in that regard. And obviously, when I say risk, again, I'm talking about criminogenic risk and not, suicide risk or risk of relapse as it pertains to substance use. So yes, we very much like to offer that type of specific content. So whether we're doing thinking for a change or aggression replacement training to address some of those specific crime producing risks that you're talking about. I don't know if that directly answers your question, but yeah, would love
Absolutely.
to discuss that more with you.
Very much. Yes, perfect. Thank you.
Sure. Yeah, thinking for a change. I've done that curriculum myself many times. It's also really good just for like new clinicians if they haven't done it before. But yeah, several of our team members are officially certified to deliver that curriculum, and some of the others that I've referenced. And yeah, look to partner with folks such as yourself who have that need. Thanks.
Real quick, just as Dr. Kang alluded, if there's a specific need, or if you are getting the information and you don't think it's comprehensive enough, we can make it as comprehensive of what your needs are, because that's why you have a representative for your region. So if you feel I need, you can contact me directly. I can work with our CMS representative for your region, and to know we can revise the information that's sent out and make sure you get what you need.
Awesome. Any other questions or comments? Okay, next slide. Ways that you can get a hold of Brightview. Our job is to make this an easy process for our partners and also for our patients. We have a 24 access line, as we mentioned before. We have treatment on demand. We have transportation assistance. medically assisted treatment services, walk-ins welcome, and on-site pharmacies at most of our locations. We provide peer support as well, case management. We want to make sure that each of our clients that we serve are treated with the utmost respect, but also given the resources they need to make sure that that we remove the barriers so they can get the help that they need. Is there any other questions?
Keith, do you mind if I mention just here a little bit about our community engagement?
Yes, sir.
So on the slide that you'll see here, we do think it's pretty important to make a point to our community partners that Brightview is not just a treatment organization. There's a ton of us, myself, Dr. King, Nate, who do outside or volunteer or outside of our kind of work on the field, and it includes a lot of this stuff. So some of these things that you see here on the list are kind of special engagements that we have that we focus on, including training, education, one of our favorite things to do, harm reduction efforts such as needle exchange engagement, as well as Narcan distribution, including the largest Narcan distribution that's ever occurred in the United States. And so we really feel like it's not extra. I think we view it as part of the things we should be doing, but we like to make mention of it because we do feel that a lot of our other entities in the space in the field don't really take the time, don't see the need, or don't make the commitment to really engaging with the community on all of these levels and putting that extra effort in. So I just want to make mention of that for a second, and I appreciate y'all attending.
Awesome. Thanks, Dr. Ryan. If there's not any other questions, I just want to thank you guys for attending our forum and for us to show you what we're trying to do in the community, but also what we're trying to do to help our patients and also our referral sources. So thank you guys again. If you have any questions, please feel free to reach out to myself or Brittany Wallace. And like I said, again, I am the East Whitehall location community outreach manager, and Brittany is the West. So again, enjoy yourself today. I appreciate your time and have a great day.
Thanks, everyone. Have a great day.